Hello, and welcome to the 2020 Cutter Foundation WISH Summit, and to the session, Dynamic Approaches to a Stigmatizing Disease, Eliminating Lymphatic Filariasis in Haiti. My name is Dr. Gregory Noland. I'm the director of the river blindness, lymphatic filariasis, schistosomiasis, and malaria programs at the Carter Center, based in Atlanta, Georgia, USA. This session features experts from Haiti and the United States working on the front lines to eliminate lymphatic filariasis, or LF, a chronic debilitating disease that is a leading cause of disability globally. Our panelists will describe recent efforts supported by the Cutter Foundation to expand clinical care for patients suffering from LF in Haiti. Then we will discuss the need for innovation in public health programs and introduce a suite of novel tools being used to assist LF elimination campaigns in Haiti. The discussion will last approximately 30 minutes. We will then have around 10 minutes at the end for audience questions. So please submit your questions via the meeting platform at any time during the discussion, and we will address as many of those as we can. Without further ado, let me introduce our four panelists. First, we have Dr. Luxen Desir, a medical doctor by training and the program manager for the Carter Center's Hispaniola Initiative based in Haiti. Next, we have Dr. Madsen Bode-Richard, also a medical doctor and currently assistant professor at University of Florida's College of Public Health and Health Professions, and a longtime Carter Center consultant. Ms. Martha Desir is a registered nurse and director of clinical services at Hôpital Sainte-Croix in Léogâne, Haiti. And our final panelist is Dr. Jim Lavery, the Conrad N. Hilton Chair of Global Health Ethics at Emory University, professor at the Emory Rollins School of Public Health, and director of the Human Engagement Learning Platform, otherwise known as HELP. Welcome to each of you. First, Dr. Desir, let me begin with you. Can you tell us more about lymphatic filariasis? What causes it, and what are the main symptoms? Dr. Desir, sorry, can you check your mute? I'm not getting any audio.
Good morning, everyone, and thank you, Greg, for your question. Lymphatic filariasis, commonly known as elephantiasis, is a mosquito-transmitted parasitic disease that affects over 100 million people in 72 countries, putting 856 million others at risk to get infected throughout the tropics and subtropics. Infection occurs when parasites are transmitted from person to person through infected mosquitoes. The parasite located to the lymphatic system where they mature into adult swarm that mate and produce millions of offspring over the course of the 5-7 year lifespan of the human host. The two main symptoms are lymphedema, or tissue swelling limb, or most commonly legs and feet, and hydrocele, male scrotal swelling. This painful and profoundly disfiguring visible manifestation of the disease can lead to permanent disability. The patients are not only physically disabled, but suffer mental, social, and financially.
And Dr. Desir, can you tell us more about the strategy to prevent or even eliminate this disease?
Since 2000, the World Health Organization launched the global program for eliminating lymphatic filariasis as public health problem. There are two strategies were adopted: stop transmission, with providing treatment for the total population of all endemic area for at least 5 years, achieving a minimal coverage of 65% of the total population. The recommended drugs are DEC, diethylcarbamazine, ivermectin, and albendazole. Nowadays, 7.6 billion doses are being distributed, and 499 million people living in 48 countries stop receiving treatment. The other pillar to eliminate lymphatic filariasis as public health problem, this is alleviate the suffering of people who get clinical manifestation, and improve their quality of life. Lymphatic filariasis is being considered as one of the principal causes of incapacity in the world, leaving more than 15 million people with lymphedema and more than 25 million people with hydrocele. The World Health Organization recommends minimum package of care that includes individual treatment to destroy any remaining adult parasite and microfilariae, and surgery for hydrocele, treatment for acute adenolymphatitis, management of lymphedema to prevent both progression and of the disease and acute attack. That means to do the management of the lymphedema, we need to make sure that we get include the hygiene, exercise, treatment of any additional skin infection.
Great, thank you, Dr. Desir. Dr. Madsen, now let me turn to you. Can you tell us what is the situation regarding lymphatic filariasis in Haiti?
Thank you, Greg. Haiti is a country of around 11 million people located in the Caribbean. And just to give you a little background, to tell you, Haiti shares the island of Hispaniola with its neighbor, the Dominican Republic. Hispaniola accounts for the vast majority, let's say up to 95% of LF in the Western Hemisphere. In 2000, Haiti embarked on a mapping campaign to determine the geographic distribution of LF in the country. We found that 84% of the communes were endemic for LF transmission. Both on that, the Minister of Health, based on that result, decided to treat the entire country. Greg, I can tell you, as of today, 86% of the commune, let's say 121 out of 140, where lymphatic filariasis has been interrupted and MBA is no longer needed. We are pretty close there. We are pretty close to stop the LF transmission in Haiti.
Great. And can you tell us more about the morbidity management, this second pillar that Luxen described? What is being done to care for patients in Haiti?
Yeah, that's based on the description of Dr. Desir about the morbidity management. And in 1994 was the year of the development of the specialized lymphedema referral clinic at Hôpital Saint-Croix in Léogane, where we are now. And with the support of the Center for Disease Control and the University of Notre Dame. After the LF mapping showing the geographical distribution throughout the country, where I mentioned 84% of the country showing transmission of LF. Based on that, many tentatives has been done to establish clinics. First, we set up a clinic to provide service for LF patients in Milo, in the North Department of the country. But unfortunately, that clinic is no longer existing. Another tentative has been made is to establish a clinic in Akaye in the West Department. Again, this clinic never materialized. Then we left up with the Hôpital Saint-Croix until now remains the only site where care for lymphatic filariasis morbidity is provided. The Minister of Health is finalizing the strategic planning for morbidity management and disability prevention with this plan to establish a clinic in each unit of implementation according to the World Health Organization requirements. This is the plan.
Great, thank you, Madsen. Now, Martha, let me bring you into the conversation. I know that you are the Director of Clinical Services at Hôpital Saint-Croix that Dr. Madsen just mentioned. Tell us from your perspective, just describe a little bit more about the care for patients at your facility.
Thank you, Greg, for bringing me to that conversation. The clinic services for lymphatic filariasis patients is functional since 1996. We provide clinical care for the patients. We teach them the basic care like hygiene, exercise, elevation. Also, we take care of acute attack. What is acute attack? It is a very painful situation for the patient. Most of the time, they have fever, pain, vomiting, nausea, swelling. They can be in that condition for 5 to 7 days, and they cannot continue with their normal life. We receive them at the clinic and provide them treatment for free. In addition to that, we understand the educational part is very important topic for the patients. We initiate more than 2 decades ago support group as an option to educate, motivate, and excite lymphatic filariasis patients about their own care, to give them real opportunities to enhance self-esteem and even to feel good about how they are helping others. There are support groups start in the family itself, where common the bond that they come to show a level of common experience and help to protect future opportunity, even in the fact in of common challenges. In Leogan, we have 10 support groups with approximately 20 numbers of members each in developed country context today to the mission of formal support group. Typically, we call those that support friends and relatives of those suffering directly from chronic illness and addictions. As an initiative to the further lymphatic filariasis patient empowerment, as a part of mental health initiative, a vocational center was opened on September 2014 as an expansion of its clinical services and mobility management. The center provide a new and important service to those individuals whose lives have been forever changed by lymphatic filariasis. The center offers courses in vocations such as sewing, tailoring, floor kits, and catering in order to provide life skills and improve self-esteem among those part with the disease, which result in incurable swelling and lower extremities. The vocational center is a key part of the spiritual, intellectual, and socio-economic life area that we experience to enhance among those afflicted with lymphatic filariasis patient disease health. As we just seen with Dr. Desir, the manifestation of lymphatic filariasis remain alive, especially lymphedema. Therefore, patients who suffer from this disease face chronic disease. They need to know how to live with it. In fact, with the collaboration of the Carter Center, we had another component in the mental care, which is the chronic disease self-management for the patient.
Great, thank you. That's really impressive work. So you're caring not only for the physical, the debilitating conditions that Dr. Desir described for us, but you're also providing holistic care for individuals, for their social, for their mental health. Martha, can you share with us, is there any example of a perspective from just one individual of how their life has been impacted or changed by receiving not only the physical, but also the more holistic social, psychosocial, even financial assistance you mentioned from the vocational center?
Yes, thank you, Greg. There are many patients in the program who can testify every day to the success of the program, though the benefits found. So, and today, I choose to talk about Antoinette Saint-Fob, who is a model of patience. She is a patient with stage 5 of lymphedema, mother of 3 children, who had a husband. With lymphedema, her image was really changed, and her husband didn't want her anymore. She was at that time discouraged, desperate, and stigmatized. In addition to the care she received at the clinic, her participation in Hope Club has allowed Antoinette to regain a taste for life. She learned skills at the vocational center, as I mentioned, that enabled her to earn a living. So she is again useful to her family. She can take care of the children. And as her husband would still like to have his relationship with her as before. It's a success for the program.
Great. Thanks so much for sharing that story. Dr. Madsen, let me return to you. Recently, I know that you, Dr. Desir, Martha, recently led a training program to train other health facilities in this type of patient care. This is something that was supported by the Cutter Foundation. It's incredibly important to mention that the work at Hôpital Sainte-Croix is the only facility presently in the country of Haiti providing this care. So this work is critical in expanding that care to other facilities across the country. Can you tell us and describe those recent activities for our audience, please?
Thank you, Greg. And that's exactly right. And Greg, let me take a few seconds just to talk on behalf of Haitian or Minister of Health in general, and on behalf of the LF, lymphatic filariasis patients in particular, to thank Carter Wish Foundation and for the funding of that training, and the Carter Center to lead that training. This is very important. This is a very good step. Effectively, Greg, Hôpital Sainte-Croix is the only one facility, as mentioned earlier, in Haiti that provides dedicated lymphatic filariasis care in the perspective to comply with the World Health Organization requirements. And the plan is to establish, as I said, one clinic in each 140 units of implementation. As we have only one from Hôpital Sainte-Croix, we have 139 to go. And this is in that perspective, the Minister of Health launched the training on September, where the National Health Coordinator contacted the Health Department on Department of West and the Artibonite to discuss about the purpose of the training and the selection, the criteria selection for the healthcare workers, health professionals in those departments. And the participants were continued, this training was conducted by instructors from Minister of Health, Hôpital Sainte-Croix, and the Carter Center for over a week. We had 11 healthcare professionals coming from those two departments, West and Artibonite, to attend the training. That training, Greg, in that training, the participants expressed their appreciation for the training, not only for the content of the training in learning new knowledge, but also with the opportunity to help the lymphatic filariasis patients in their respective department where there is a great need. And now this was a rewarding experience for the instructors, participants, and the Minister of Health officials. Those two clinics will be in function by the end of the year. This is the plan.
Great. And so just picking up on that last point, are there plans to expand this type of training to other areas within Haiti?
Yes, Greg, you can imagine, the plan is to move forward on those, exactly with the addition of the 2 more clinics that will make us at 3 clinics in total for the country. But remember, we have 140 communes. That means we have 137 more to go. Where is funding is available. The current plan is to train healthcare professionals from the remaining 137 communities. As we are close to the end of LF transmission, conduct the training and establish clinic is necessary steps in the process of lymphatic filariasis elimination dossier and the benefits for alleviate the suffering of lymphatic filariasis patients. This is the plan, and this is where we want to go. Okay.
And then finally, Luxen, let me bring the conversation back to you. Can you describe for us how does the successful implementation and achievement of these trainings help Haiti achieve its goal of eliminating this disease?
Thank you, Greg, for that question. So I described at the beginning, in 2000, the World Health Organization launched the program, the global program to eliminate lymphatic filariasis as a public health problem. They had two strategies. First, stopping transmission, and the second, this is alleviate the suffering for people who get lymphedema or hydrocele. So, to be able to receive, to present our dossier to eliminate LF as public health problem in any country, the country must provide clear understanding, not only stopping transmission, but also presenting data showing activities on mobility management and disability prevention. So, doing that training to compare with the World Health Organization requirement, the country is finalizing a strategic national plan where it's recommended that one clinic should be established in the transmission zone in Haiti. As of before the training, Hospital Saint-Croix was the only site where care services were available for the control of mobility, lymphedema, and hydrocele, including essential basic hygiene and wound care for lymphedema and corrective surgery for hydrocele repair. It was in that perspective that the Carter Center led the training for mobility management funded by the Carter We Foundation to comply with the World Health Organization requirement. This will help in starting establishing the integration in health system of the first two new health facilities in order to provide adequate care for mobility management services with minimal equipment. But the Carter Center is not only looking for elimination lymphatic filariasis in Haiti. We hope, this is our goal, our wish, to eliminate lymphatic filariasis as public health problem in the entire island. When we talk about entire island, we think Dominican Republic and Haiti. At the same time, we are collaborating with the colleagues in Dominican Republic to achieve those goals. We are helping them in doing MDA right now. The Dominican Republic, they do already stop transmission, stop MDA in all the endemic area, and now we are moving in the mobility management to be sure both countries in the island can be eliminated, can be certified for eliminating lymphatic filariasis as public health problem. Thank you.
Luxen. Let me now bring in our other guest, Dr. Jim Lavery, to talk about innovation within public health programs and specifically within programs like the effort to eliminate LF in Haiti. And as a reminder for our audience, please feel free to pose questions within the meeting platform. We do intend to take questions in a few minutes at the end of our discussion. So please keep those questions coming. Jim, welcome. Let me turn to you. First, let me pose a general question to you. Why the need for innovation in public health programs in general?
Yeah, well, thanks, Greg. It's a pleasure to be here with you and our wonderful colleagues from Haiti. You know, I think we tend to think about innovation almost exclusively, I think, in terms of new technologies. But, you know, in fact, some of the most important innovations have been social innovations or things like business process innovations. And an example that I always like to use and I don't think we look enough at these examples in global health, but one of the examples I like to use is the development of the Toyota production system that revolutionized car manufacturing, but also led to a major revolution in manufacturing and supply chain management really in every sector in the world. And, you know, the industrial engineers, Taiichi Ono and Eiji Toyoda, who was also the president and chairman of Toyota, are widely credited with the development and articulation of you know, what has become known as the Toyota production system. And one of the central innovations that they introduced was this idea that the workers on their manufacturing plant floors who were actually assembling the cars had a unique type of knowledge and insight about the way that the manufacturing process was actually working. And that this knowledge was essentially being wasted because these insights weren't being harnessed by the company to solve problems and improve the company's performance. And so, you know, one of the core tenets of this Toyota production system is that, you know, continuously solving what they thought of as root problems drives organizational learning. So the point, Greg, and bringing it back to global health, the innovation was fundamentally a human innovation. We tend to think about these things in terms of engineering or technologies, but it was really fundamentally a human innovation. This idea of recognizing and privileging the knowledge and the wisdom of the people whose opinions were rarely or never sought by managers or decision makers, and in this case, in car manufacturing. But I think that this is a widespread challenge in global health programming as well. And so I think one of the places that we need to pay more attention to the innovation landscape in global health is the human ecosystem, or what we call in our work at the Human Engagement Learning Platform, the human infrastructure of global health programs.
Thanks, Jim. And so can you describe for us more specifically, thinking about the LF elimination efforts in Haiti as a particular context? How do these innovative ideas take shape? How can they be applied to improve LF implementation efforts?
Well, Greg, we've been working together with Luxen and Martha and Madsen and the Carter Center for a couple of years now to try to help pinpoint some specific aspects of mass drug administration programs for LF elimination that, you know, could possibly be improved to try to drive up coverage rates, and which, you know, with the aim of trying to speed elimination of LF in Haiti. And, you know, at HELP, our work was focused primarily on stakeholder engagement and knowledge co-production strategies. In other words, how, you know, programs interact with the teams and the workers that are running the programs, but also those stakeholders and community members that we're trying to reach to encourage them to take the drugs that we hope will protect them and eventually drive down disease transmission. But in the first major study that we undertook for the Carter Center and that introduced us to Luxen and Madsen, what we discovered was that the drug distribution teams were learning a lot every day during the implementation of the MDA programs. So, you know, if you go back to the Toyota terms that I just introduced, the drug distribution teams were essentially the sort of frontline workers or the assembly line floor workers. And what we found in our study was a lot of examples of how they were solving what the Toyota people might have called root problems in real time. There was a lot of ingenuity going on in the human interactions and the delivery of the MDA. And the problem, though, was that their insights and the solutions that they were generating to these problems were, they weren't making their way back into the program. So there wasn't a lot of learning that was being translated into continuous improvement of performance. And then this had resulted, I think, in an overall loss or lack of kind of increase, if you like, in coverage rates over time. And then, but when we started our discussions about our findings with Luxen and Madsen and the Carter Center, you know, we were kind of anxious that our findings would be seen as negative and critical, and might result in frustration or discouragement, which is the very last thing that anyone needs when you're trying to eliminate a disease like LF, for all the reasons that Madsen and Martha and Luxanne have described so nicely so far. But, I'm not sure whether Luxanne and Madsen, and all of you guys at the Carter Center were big fans of Taiichi Ono and Eiji Toyota, but what we found was just an amazing willingness to sort of view these findings as an opportunity to start to build the learning capacity of the MDA program so that there could be more reliable improvement year over year in the MDA coverage. And they've really made excellent strides, I think, already in improving a number of key aspects of the MDA, with great results in the last round of MDA in last spring.
Great, thanks. So really not an outside in or top down approach to innovation, but the approach you described really sounds like it's providing opportunity for listening and communications with those frontline workers, the folks who are engaging and interacting with the communities that we are trying to serve, the communities we are trying to reach in that manner. So really trying to just provide better tools for listening to ground level innovation. Is that really what I'm hearing you say?
Yeah, well, and I'd take it a step further, Greg. I think there's increasing recognition that this idea of listening is actually a component of communications. People have been saying this, of course, for hundreds of years, but it's not until things get published in Science and Nature with ideas like co-production and the improvements that can follow with this that I think people start to really take it seriously. Where I would extend your point, though, Greg, is that it's not just about listening. The real innovation in Toyota was they listened, they heard, they understood that there was a kind of knowledge that was tacit in the workforce, and then they redesigned their management strategies to incorporate the learning so that it would actually be actionable and actually contribute to improvements. And back to my comments, I think one of the things that has made our collaboration with the Carter Center and Luxanne and Madsen just such a wonderful collaboration is exactly this kind of willingness to look at how those insights might be turned into improvements in performance. And like I said, I mean, we're already seeing this with great results in the last round of MDA.
Thanks, Jim. So let's talk about MDA then specifically. So for the audience who may not be familiar with a mass drug administration campaign, can you give us a sense just of the size and scope and scale of one of these campaigns within Haiti?
Yeah, well, and I mean, I'm a good deliverer for this message because I had to learn this myself, and I think trying to get your mind around the scale and the complexity is really it's quite an impressive infrastructure that's required. So in the MDA that Luxanne and Madsen and Martha are about to embark on in the next couple of weeks in Léogâne and Gressier in Haiti, we're looking at first of all, the organization is you have to get drugs into the supply. You have to distribute them quickly in the course of a few days, and the way that it's done is to break down a region into distribution regions, and here the usual approach has been to have people come to a distribution post that's maybe in their neighborhood, for example. And in the upcoming MDA, there are I think there are 326 distribution posts in total. I think about 54 of them in Gressier and 272 in Léogâne. And each of those posts will have assigned to it 4 community drug distribution members, like a drug distribution team. So that means there'll be about 1,304, if I remember the numbers correctly, distribution staff alone. And then you have an additional 125 field supervisory staff. So if you go back then, Greg, to this idea that we need to do better at organizing our learning in real time for these drug distribution teams interacting with the communities and within the program itself, then what you get is a very, very complex social enterprise that really has to be harnessed effectively.
So, Jim, one of the unique features I know you and I have talked about is the opportunity to learn and to incorporate those lessons, not only from year to year, as these mass drug administration campaigns need to be implemented for a minimum of 5 years, according to World Health Organization guidelines. But some of these tools that you are describing really, in fact, offer the opportunity for even day-to-day learning. I mean, can you just describe that a little bit more? I mean, is that possible, and how do we translate those messages, those learnings, to program staff really in real time?
Yeah. So, and Greg, it's a great framing the question because, and let me just tell you a brief story about this, because I think sometimes in innovation you need to have your framing adjusted so that you'll be hearing and learning things that you can take advantage of. And let me just tell you a brief story about our program and some work that we've been developing with Luxen and Madsen and Carter Center. As we all know, we're trying to increase coverage rates, and as we get closer and closer to elimination, the final improvements are often the hardest and often the most expensive. And so we're actually pursuing an innovation right now, Greg, as you know, that really picks up on the point that you just made. So in last summer, my team at HELP, we had an opportunity to participate in an innovation boot camp that was run by the World Food Program around a grant that we have with the Bill and Melinda Gates Foundation. And as I've just described, we're intensely focused in our work at the moment on these issues of organizational learning around LF in Haiti with Madsen and Luxen and the Carter Center. So, one of the presentations we heard in this boot camp was by a guy named Coit Manuel, who's the CEO of a startup company called Crosscut. And he was presenting about how his company can create really comprehensive microplans. And, for those of you who aren't familiar with microplans, just imagine all of those different distribution posts that I told you about. And what microplans do is they create sort of very detailed maps and population estimates, but also, complex supply chain data management systems that can sort of help with the organization and planning for how to distribute drugs. And so when Coit presented his company's technology, I said to my team, we've got to meet this guy. This could really help Luxen and Madsen to coordinate the planning of the NDA campaigns for LF. And then, we got even more excited with the next presentation in this boot camp by a guy named David Hamill, who's the CEO of a company called Balcony. And the Balcony technology is a geospatial communications technology. So Balcony can draw a boundary on a computer map. David can be sitting in California, draw a boundary on a computer map. Imagine maybe one of the maps that Crosscut creates for a microplan for a specific drug distribution post or for a number of drug distribution posts. And then anyone who has the Balcony app downloaded on their smartphone and who actually walks into the real geography corresponding to the boundary that have been created can immediately then engage in like bidirectional communications through this Balcony app. And so when we saw this, immediately we thought, well, this is an amazing way to bring our focus on organizational learning just to the next level. So the human infrastructure part, I think, is really making great improvements. And these technologies, in part because we were focused on this as a problem, these technologies offer just an amazingly elegant way to pull these different components, the microplanning, the stakeholder engagement interface, and to pull them together through this Balcony communications technology. So we're hoping to pilot this model that we're calling the PEAL model. So it's PEAL stands for planning, execution, and engage to learn. And we're trying to, pilot this this PEAL model with Luxen and Madsen and Carter Center and Balcony and Crosscut and HELP, hopefully in the fall of 2021.
Great, thanks, Jim. Let's wrap it up there. I know we do have some questions coming in, so I want to make sure that we have a chance to get to those. But Jim, thanks so much for sharing about this innovative thinking. And obviously we continue to be excited about those developments. Martha, there's a question that I think would be good for you to address. The question says, LF seems to be such a disfiguring disease, but what are the mental health implications of this disease and those who suffer from LF? I know, Martha, you mentioned very briefly some of the focus on mental health care specifically that we are piloting. Can you just, in maybe 60 seconds or less, summarize for us just some of those activities?
Thank you, Greg. Very briefly, as I've mentioned, LF patient is a really mental affect patient. So that's why in the clinic, we are not taking care only physically, we are taking care of patient mentally. We have the mental, the vocational center where we teach people, because we know with the that mental disease, that chronic disease, patient has a lot of loss. They lost job because with their parents, so they afraid to give them work. They are lose. They are also a social and financial affect. So in the mental initiative, we try to help those patients to have some skills and ability to be useful to their community, to be useful for themselves. So at the mental health initiative, we are providing skills and ability for those people to help themselves.
Great, thank you, Martha. Another question here asks about the impact that Haiti, and in fact the island of Hispaniola as a whole, is constantly at risk of natural disasters. Obviously the earthquake of 2010 was a devastating impact on the country, and also hurricanes that seem to be coming with increasing frequency and severity. Madsen, let me ask you, how have the programs been able to continue working in the face of these natural disasters?
Yes, great, thank you. And that's correct. I think Haiti is in a situation, many natural disasters and even political situation. Haiti is struggling, as many other countries are struggling with maybe different adversities. But for Haitian, as I would consider lymphatic filariasis as a model that we continue to pursue despite of all those challenges. Facing the earthquake, I think right after we start activities. Even in the midst of 2004, there was a very contentious political battle. And at that time, we keep moving on the distribution what I was planning. Sometimes we have few delays, like considered with the COVID situation. But right before the COVID, even there are some, struggle about within the country. But we did MDE. That means the plan that we have, the motivation to stop the transmission in Haiti. I think this is, sometimes we put it above, not risking any lives, but we keep continue moving as we see there's an opportunity to keep moving. Even despite of all the challenges, difficulties, when the opportunity to move, and we continue. And that means the staff, really motivated to get that done as we plan.
Madsen, sorry, let me interrupt you there in the spirit of keeping moving. I'm getting a signal that we need to keep moving with the session. So thank you so much. for all of our panelists, and certainly thank you to our audience. We hope you found this session educational and also inspirational. So on behalf of all the panelists, myself, Greg Noland here at the Carter Center, we hope that you enjoy the rest of the WISH Summit, and we bid you a good day. Thank you so much for joining.
Thanks.